Welcome back to the Best PT Podcast. This is episode 3.8, talking about peripheral nervous system lesions. Let's begin with common causes of peripheral nerve injuries. The axillary nerve is often injured when there is a fracture of the neck of the humerus or anterior shoulder dislocations. The musculocutaneous nerve is often injured with a clavicular fracture. The radial nerve, injured via compression of the nerve through the radial tunnel or with a humerus fracture. The median nerve can be compressed in the carpal tunnel or with pronator teres entrapment. The ulnar nerve can be compressed as well through the carpal tunnel or entrapped within Guillen's canal. The femoral nerve can be injured during a total hip replacement, a fracture of the acetabulum, an anterior dislocation of the femur, a hysterectomy, or an appendectomy. The sciatic nerve can be injured via blunt trauma to the buttocks, a total hip replacement, or accidental nerve injection of the sciatic nerve. The obturator nerve can be injured during a total hip replacement or with an open reduction, internal fixation of a femoral fracture. The peroneal nerves can be injured with a femoral, tibial, or fibular fracture or due to positioning or compression while sedated during surgery. The tibial nerve can be injured via tarsal tunnel entrapment or popliteal fossa compression, and the sural nerve can be injured with fractures of the calcaneus or the lateral malleolus. Different types of peripheral nerve injuries. Double crush syndrome occurs when two separate lesions occur on the same nerve that creates more severe symptoms than if just one lesion was present. Mononeuropathies are isolated nerve lesions usually due to trauma or entrapment. Neuromas are abnormal growths of nerve cells due to vasculitis, AIDS, or amyloidosis. A common type of neuroma is Morton's neuroma, which occurs between the second and third or third and fourth metatarsal heads due to compression of the intermetatarsal plantar nerve. So this is usually caused by narrow shoes. So ladies, those shoes you wear that make your toes pointed and look like a witch, or high-heeled shoes. Any type of shoe that compresses and crushes the toes together can lead to Morton's neuroma. Peripheral neuropathies can be caused by an impairment or dysfunction of the peripheral nerves due to diabetes, trauma, or chronic alcoholism. Polyneuropathy, diffuse nerve dysfunction that is both symmetrical and bilateral secondary to pathology such as Guillain-Barré. Peripheral neuropathy, the use of neurotoxic drugs such as those in chemotherapy or HIV. And finally, Wallerian degeneration is peripheral nerve degeneration that occurs distally below a nerve lesion, specifically degeneration of the myelin sheath and its axon. Classifying acute nerve injuries. The most mild form is neuropraxia. Axon continuity is preserved. Nerve conduction is preserved both proximally and distally away from the lesion. There is no nerve degeneration. Symptoms include pain, minimal muscle atrophy, numbness, and slightly diminished proprioception. Recovery is fast, approximately 4 to 6 weeks. This occurs most often with pressure injuries. Axonotomesis is a more severe grade of peripheral nerve injuries. It's reversible injury to damaged nerve fibers. Wallerian degeneration can occur. Nerves can still regenerate distally at a rate of about 1 millimeter per day. Recovery is usually spontaneous, ranging between spotty recovery or no recovery. Surgery may be indicated. This occurs most often with traction and crush injuries. Finally, the most severe grade of peripheral nerve injury is neurotemesis. The axon, myelin sheath, and connective tissue are all damaged, possibly completely transected. In this stage of injury, irreversible injury has occurred. Signs and symptoms include flaccid paralysis, muscle atrophy, and total sensation loss to areas supplied by the nerve. There is motor and sensation loss distal to the lesion, and surgical reattachment may allow axons to regrow at a rate of 1 millimeter per day, usually presenting with greater proximal than distal recovery and greater recovery in sensory rather than motor fibers. This occurs when there is a complete transection of the trunk of a nerve. Getting into specific peripheral nervous system pathologies, damage to anterior horn cells results in intact sensation but motor weakness and atrophy, fasciculations, decreased or absent deep tendon reflexes. Injuries that lead to anterior horn cell damage include ALS or Lou Gehrig's disease as well as polio. Damage to the muscle directly results in intact sensation, motor weakness, very rarely resulting in fasciculations with normal or slightly diminished deep tendon reflexes. Examples include muscular dystrophy. Neuromuscular junction damage results in intact sensation, motor fatigue, more impaired than actual motor weakness, normal deep tendon reflexes. An example of a neuromuscular junction injury is myasthenia gravis. Peripheral nerve motoneuropathies result in sensory loss, motor weakness, and motor atrophy along the nerve distribution. Fasciculations are possible. These are usually caused by trauma or compression. Peripheral neuropathies present with sensation loss and a stocking glove pattern. Motor weakness and atrophy are present as well. Weakness is distal, greater than proximal. Fasciculations are possible. Deep tendon reflexes are decreased. An example is diabetic peripheral neuropathy. Spinal root or spinal nerve damage results in sensory loss corresponding to the appropriate dermatome, motor weakness corresponding to the appropriate myotome, possible fasciculations, and decreased deep tendon reflexes. An example is a herniated disc. Upper motor neuron diseases are lesions of the descending motor tracts within the cerebral motor cortex, internal capsule, brainstem, or spinal cord. It involves weakness of involved muscles with hypertonicity, hyperreflexia, mild atrophy, and abnormal reflexes. Examples include cerebral palsy, hydrocephalus, ALS or Lou Gehrig's disease, strokes, birth injuries, multiple sclerosis, Huntington's disease, traumatic brain injuries, and brain tumors. Lower motor neuron disease result from lesions of a motor neuron or its axons at or below the level of the brainstem. These result in flaccid, weak muscles with decreased tone, fasciculations, muscle atrophy, and decreased or absent reflexes. Pathologies resulting in lower motor neuron disease include polio, ALS or Lou Gehrig's disease, Guillain-Barré syndrome, spinal cord tumors, spinal cord trauma, Bell's palsy, infections, carpal tunnel syndrome, muscular dystrophies, and spinal muscular atrophy. Moving on to involuntary movement disorders, we have tremors, which are involuntary, rhythmic, and oscillatory in nature. 3 types of tremors. The first, resting, which may or may not disappear with movement, can increase with mental stress. An example is pill-rolling tremor as seen in those patients with Parkinson's disease. Postural tremors, observed during voluntary movement, performed to maintain posture. Hyperthyroidism, fatigue, anxiety, and benign essential tremor can all lead to postural tremors. Intention or kinetic tremors begin with movement and worsen as movement nears its target. So reaching your hand towards a wall, the tremor will increase as your hand nears the wall. These occur with lesions of the cerebellum and multiple sclerosis. Tics are sudden, brief, repetitive movements occurring at irregular intervals. Examples include myoclonic jerks and Tourette syndrome. Chorea is hyperkinesia, brief and irregular contraction movements that are not as severe as tics. These are usually caused by caudate nucleus damage, can be referred to as fidgeting, and a common disease that presents with choreiform movement is Huntington's disease. Dystonia is sustained muscle contractions that deal with twisting, abnormal posture, and repetitive movements. Parkinson's disease, cerebral palsy, and encephalitis can all lead to dystonia. Patients can also have what's called dystonic storums, where they have sustained muscle contractions lasting for a very long period of time, causing extreme pain and fatigue. The final type of involuntary movement is athetosis, slow, twisting, writhing movements that can be large in amplitude. It is a common finding in cerebral palsy. Different types of muscle movement impairment. Akinesia is the inability to initiate movement, such as in Parkinson's disease. Agenesia is generalized weakness secondary to cerebellar pathology. Ataxia is an inability to perform coordinated movements. Bradykinesia is slow movements but still able to initiate. A clasp knife response is a form of resistance seen during range of motion due to hypertonicity. Greatest resistance is felt at the beginning of the range of motion that lessens with further movement. Clonus is secondary to upper motor neuron lesions. It is an involuntary spasm contraction due to a quick stretch reflex. You can elicit this most commonly at the ankles by performing a quick plantar flexion stretch. The patient's ankles will then pump involuntarily. Cogwheel rigidity. Resistance to movement increases and decreases throughout the range of motion. Dysdiadokinesia is the inability to perform rapid alternating movements. So the patient will not be able to rapidly perform pronation or supination of the forearms or perform alternating toe taps. Dysmetria is the inability to control both the range and force of your movements. Fasciculations are muscular twitches indicative of lower motor neuron disease. Hemibalism is the involuntary and violent movement of a large body part. This is usually seen with choreiform movement. Lead pipe rigidity is resistance to motion that is both uniform and constant. And then finally, the definition of rigidity is any severe hypertonicity that does not allow movement at a joint. That's it for episode 3.8, talking about peripheral nervous system lesions. The next episode, 3.9, will talk about the balance and vestibular systems. As always, the outline will be in the show notes. Thank you for joining me.